Well, it's just turned 6 o'clock, so good evening and welcome to our Wednesday evening webinar. This evening we have a really exciting program. I think all of us realize just how important cardiothoracic surgery is within the specialties of surgery, and what we're getting this evening is an update in recent developments, and we're very fortunate to have David Healy, Aisling Kinsella and Karen Redmond, three leading cardiothoracic surgeons with interests in transplant and in thoracic surgery, and Karen is going to talk about the particularly difficult problem of tracheomalacia. As always, we'd be grateful if you could mute your microphones and not use the camera. That way we can focus on the presentations. And if you have questions, please use the chat function and we will use that to put any questions that you have to the panel. And I'm going to ask David Healy, who will act as the Master of Ceremonies this evening, to start with this presentation on robotic thoracic surgery. Thank you, David.
Well, thank you very much, Professor. I'm going to introduce my colleagues in due course, but I'll just start with my own presentation first and then give you the details on my good colleagues, Ms. Kinsella and Professor Redmond. Just to share this now with you, I'll share my screen, which hopefully is working for you now. You're seeing the presentation there, robotic thoracic surgery?
Thank you, David. That's perfect.
Okay, good. So this is what I'm going to speak about for a few minutes. Robotic surgery is certainly something a lot of people have been interested in and trying to get involved in, and it's certainly an exciting addition to Irish surgery in recent years. I just would like to start by declaring I am an invited speaker for Intuitive Robotics and a coach for them. But the background to this, I suppose, is this is historical chest surgery. This is a thoracotomy, big spread of the chest, ribs pulled apart, enough to get a hand in, a lot of mechanical instruments spreading the chest. So this is what we're all trying to avoid. And in fairness, we don't have to go into that too much. We know there's a lot of trauma involved, a lot of pain. There are oncology implications for this, adhesions for further surgery. And we're certainly very heavily audited and regulated specialty. And we know that in open lobectomies versus minimally invasive lobectomies, the mortality at 30 days is actually significantly lower in Ireland and England in this day and age, with a 1.3% mortality in minimally invasive approaches versus 2% in open approaches. So the world has moved to minimally invasive surgery, and this is minimally invasive thoracic surgery with VATS or laparoscopic equivalent surgery, small cuts on the chest. And I like this picture because here's an old thoracotomy incision there, and this is the contemporary sort of scars that we're using. So considerably smaller, and the scars are much better. We get away with a lot in chest surgery because the organ we're working on is the lung, and it's full of air. So we can put it in a bag and it really compresses down and squeezes out through a very small hole without too much difficulty. It's the tumor that decides the hole size, really. But in terms of VATS or equivalent laparoscopic surgery, the limits for us are very much the instruments. And in many ways, there's no reason why the instruments haven't developed in the recent years. There's no, you'd think there would be a lot of interest in developing more sophisticated laparoscopic or thoracoscopic instruments, but instead the flow of the river and the momentum and the financial investment has gone into robotics. And really, some of the key differences between what we're doing and robotics is really in the instruments. The operation is largely the same internally. I think I would just remind people that robotics is nearly old. It's 20 years since the Da Vinci machine was first released into the world. Part of the reason that a lot of Da Vinci robots have appeared in Ireland in recent years is that they've come towards the end of their patent life, and they're keen to get these in place before the competition arrives. That's the honest truth of it. But the major advantage of robotics are there's a 3D camera, and as a surgeon, the operating surgeon, you control it, and you can move it any way you want, and it stays where you want it to go. It doesn't drift off as they dream of the beach. And the instruments are the other key difference. A typical robotic or typical laparoscopic instrument is a stick that you can move around. You can open and close a jaw, and you can rotate. With the robot, you get a wrist. You can do this. And that's the key difference between the two. So just to switch to a little piece of video, just to give you an idea of what we get up to. This is standard preparation. You're familiar with that. That's our robot. The robot goes in through little ports. If you look on the screen in the background here, you can see introduction of a port, thin band and a thick band, which is the pivot point. So you try and get that thick band at the rib level. I tend to put a bit of local anesthetic in before we make any of these holes, even under general anesthetic. It seems to help with post-op pain. So that's the port going in. Thin band, you wait for you see the thick band, which is where the instrument pivots. So this is the instrument being brought in. This is the Da Vinci robot, XI with 4 arms, easily controlled by the team. The position is helped by dropping a green line marker that guides your positioning. You line up that green light with the port that is going to be your camera port. And then you build the setup around that. So the arm gets connected to the camera port. Camera is introduced. If you look at the top left corner of the screen here, you'll see what the camera is seeing. Down the port into this pleural space. So we get the rest of the arms connected up. And the instruments attached. So these are the instruments inside the chest. A spatula in this hand. 3 instruments in. And as you can see, the flexibility and motion is what it's all about. So onwards and upwards with the operation. This is what you see from the outside. You have an assistant at the table helping with extracting specimens, changing instruments, suction, stapling on occasion. CO2 insufflation you're familiar with. Bipolar and diathermy you're very familiar with. Don't need to talk about that really. Everyone in the room can see what's going on. It's on a display, so your assistants to see, or students, or anyone that can have as good a view as you have. Surgeon sitting down, certainly a recipe for hopefully a long surgical life for your back anyway. It's a hands and feet operation. The feet help control the camera and some of the instruments. So any cancer operation is the same, whether it's robotic, VATS, open, it's lymph nodes and the primary. So here we are on the left side, heart over here, aorta here. We're going, the inferior pulmonary ligament is here, and we divide that and come up to lymph nodes. One of the key features felt about robots is that you do a very good lymph node dissection. Again, this is lovely and color coded and very easy for chest surgeons. Just follow the black marks, is it, for the lymph nodes. It's lovely dry surgery, and you can see the instruments, the way you kind of move them. You have lovely fine movements. This is very magnified as well. So inferior pulmonary vein is here. We're going to move up to level 7 node here shortly. Aorta here in the background, upper lobe, and then the level 7 node. So we've done the back and lymph nodes around the back. We're going to flick to the front. And here you can see the phrenic stripe, heart beating underneath. This case is an upper lingual asperian upper lobectomy, so we're most interested in the upper lobe vein. So we start exposing that, and while we're there, we're also going to find some lymph nodes on the way. So this is the lymph node coming out. And then this is the superior vein. Now, with this particular operation, I'm trying to leave the lingula vein here alone. The lingula is equivalent to the right mid lobe, essentially on the left. So I'm trying to take out the true left upper lobe vein on this side, leave the lingula drainage alone. So we get around that with our instruments. pop a cord, and then use a stapling gun. Fire that, and there we go. Now we're in the fissure. We're going to hunt for the pulmonary artery in here. Sorry, I've gone on a bit too quick there. There's the white of the pulmonary artery here being exposed. Upper lobe on the left, lower lobe on the right. Follow the pulmonary artery, punch a hole through here, and separate the fissure of the upper and lower. Staple guns are what make this operation doable as well. So now in the background, you can see the arch of the aorta, left upper lobe on the left, left lower lobe on the right. These are individual segmental branches from the pulmonary artery into the left upper lobe. I'm going to try and pick out the ones addressing the true upper lobe. I'm going to leave the ones under here into the lingula. Don't leave them alone. Again, we sneak around them. Be fairly careful with the pulmonary artery and staple them. After that, we address the bronchus to the upper lobe. Again, this is just a loop around it, staple and divide. So I'm keen to take out the true upper lobe. I'm keen to leave the lingula, or if you want the right mid-lobe equivalent, alone. There is no demarcation, so to do that, I'm going to use an ICG dye and fluorescence. So what we do is I've divided the inflow, the arterial inflow to the true upper lobe, but not to the lingula. So when we give the dye and give the fluorescence, you can see the green lights up the part of the upper lobe that's still perfused, that we want to leave behind. And the grey bit that we want to take out will become demarcated and gradually as we give it a little bit of time. So you can see this portion down here, this triangle down here, equivalent to the middle lobe, is going to be left behind, and we're going to shoot a staple line across that division there. This is one of the key advantages of the robot. I know this can be done open, but it's certainly easier with this. This is all built in the robot. Again, that dye will wash out quick enough, so I put little markers along the line for myself. If I find that I haven't stapled them before the dye is through, but after the dye is washed off, I'll have something to work with. Staple guns again. And again, just to emphasize, we'll flick back away from the fluorescence for a second and just emphasize that under normal vision, you wouldn't see these that distinction between the lovely green area here and the gray in the background. Under normal vision, it all looks the same. There's no real distinction. So we complete that. Out it comes in a bag, and off we go. The robot is a Da Vinci Xi, the one we happen to have that's on this video. It's 4 arms. The eyepiece, 3D camera. Your head sits in here, resting against there. You can have your own settings in terms of ergonomics, the height, all that kind of stuff stored. It's a hands and feet operation. These are the fine controls. And then we say, bye-bye robot. So that's the robot. From my point of view, just to share the journey briefly on how to get there. I was, like all of us, we all travel. When I was in Sloan Kettering in 2010, 2011, they had just institutionally decided to take this on as a goal. They had purchased a number of robots. Being that sort of institution, they don't buy one, they buy a fleet of them. And I happened to be there when the attendings or consultants were learning. So in truth, I was very much at the bottom of the learning pile, but that was fine because I got to see a program and how to safely introduce this kind of thing. So when I came back to Ireland, there was no robot available to me. So it was 2017 that St. Vincent's got its first robot. And at that stage, I went back to Sloan Kettering to get some updated training. Went through a program from January to October in 2018, took the 10 months to get there. And then you get a hospital accreditation committee. So the pathway is an online robotics course, which is fairly straightforward. And for thoracic surgery, it's different for them all. But for us, we had to do 40 hours of simulation. The computer simulator really is excellent, and it scores you on your performance and gives great feedback on how you're getting on. You have to travel and do some courses and get your certificates on that. And I went to Strasbourg for 2 blocks of 2 days. and then you go and visit the real thing. So I went and saw surgeon Marion Durand in Paris, and we watched her operate for a number of procedures, and she took us through a collection of videos that she had. And then on another visit, we went to a cadaveric lab that she has access to with a robot, and we were able to do some work there. Then when it's up and running back in Dublin with a mentor, we do 6 cases. I had proctors from Finland, Netherlands, France, and the UK, and they give you a scorecard and how you get on and what you need to work on. And then at the moment, the mechanism then is it's very much down to individual hospitals. St. Vincent's happens to have a robot committee. You put in all your paperwork and you get a credentialing decision from them. And as you can see here, they give you conditional approval, I suppose, and you're under constant follow-up. In terms of robots in the real world, the main messages are there's certainly less pain. You probably do a better lymph node dissection. There's definitely less blood loss and a shorter hospital stay. Challenges, of course, are familiar to everyone. There's the cost involved, but I think as surgeons, we sometimes underappreciate what we do and don't put a true value on what we do. And I think particularly in the oncology world, no one questions the costs of most of those drugs, many of whom are not curative. And cancer surgery is often the only true cure option for a lot of these patients. And I think an investment on good technology and good equipment and good space to get this done is appropriate, and we should be mindful of that relative to a lot of other things, our costs are actually quite low. You might have seen in the video, the room is quite small that the robot has to be in. That seems to be a feature. Robots take up a lot of space, and they probably need your biggest room in the building. And I suspect future theatre bills will have to take that in time. It can be a bit slower, certainly at the beginning, although you do get that down quick enough. And if you're in a robot team where the room that you operate on and the nursing staff use robots every day for you and for other surgeons and other specialties, you find that a lot of the time loss, there's a lot of time savings that can be made very quickly in the program, and you can pull back your times quite quickly. And I suppose the main challenge that we all face is access, because most hospitals have a limited number of robots relative to the number of surgeons who are interested in doing it. And it is at the moment very much a rationed resource. And I guess at the end of the day, not all surgery can be minimally invasive surgery. And at the moment, we haven't seen a lot of supply competition in terms of robots, despite a lot of talk and hope and things like the Versius robot and these sort of products. But at the moment, there's still really a dominant single supplier in the market, and cost, etc., will probably change when that situation changes. So I'm going to stop there. I think by and large, I'd say to everyone that robots are something people should be interested in. You should be getting your trainees involved in. Personally, you should probably be involved yourself to future-proof your career. I think there are huge advantages to patients. I'm truly, honestly surprised from the patient point of view of how well they recover. I didn't expect a difference from VATS to robot would be as big as it is, but it is. And certainly as a surgeon, I think your career is probably going to last a bit longer, because you get to sit down and maybe have a cup of coffee on the side cup while you're operating, which is certainly a rare privilege. And on that note, I will return the sharing to the rest of the team. Okay, so we're back to the general. I've stopped sharing now, have I?
Yes, you have.
Yes, you have.
Yeah. Thanks, okay, David, for that. Just I see a question in from Paul Balfe, and we were all looking at the transition between the indocyanine green and the the non-green area. And he wonders, do you have to oversew the staple line, or do you have to oversew the bronchial staple line?
Oh, fairness, Paul and co, we've gotten very dependent and confident and reassured, and have lots of experience, I suppose, and good experience with staples now. Whether it's VATS or robotic, I mean, you are relying on the staple line to hold, and they do. And so we don't oversew them. Certainly the bronchus we don't oversew, or the suture line, or the lung edge. Clearly, in terms of post-op air leak, that's where most of your concern is going to be, the lines that you divide. But philosophically, a lot of surgeons talk about fissure last. In other words, you do all your dissection and then at the end finish off the edge with staples. So we do have a lot of confidence in the staples, and we don't oversew them.
And David, just another question. There was a lot of talk about robotic assisted coronary artery bypass, and that you could synchronize with the movement, so you could do it on the beating heart. Was that just a pipe dream, or is it a reality?
That isn't a reality anyway. I mean, I've heard people, I've never seen that as a presentation. I've heard people say that they've seen it presented, that the robot moves with the beating heart in sync. The current technology available in the real world doesn't have that ability to sync with it. I'm sure there are labs working on it, but what Da Vinci have in the market can't sync with a heartbeat. But it's a nice idea, I suppose, and it's certainly a potential. From my point of view, for example, robotic cardiac surgery is another box of tricks in terms of certification and hours on a simulator. And at the moment, you can't be trained in Europe or proctored in Europe in cardiac robotic surgery. You have to go transatlantic. So we certainly haven't got that going here yet. So I suppose thoracic surgery in truth lends itself enormously to any minimally invasive approach. You have a lot of space in the pleural cavity and ribs holding up the box for you. So a lot of nice work can be done minimally invasively in the chest. Cynics also say that
esophageectomy.
Fair enough. I suppose when I was in Sloan Kettering, yes, the thoracic surgeons there did esophagectomies, and certainly they were working on a robotic program there. We haven't, and we're not, and I can't really speak to that because in Ireland, I guess the esophagus is an upper GI zone in the NCCP program, so it's not a direction that we're going on. I was just going to say some cynics say that minimally invasive cardiac surgery is cardiology, but there you go.
David, I'll hand back to you to introduce your colleagues and to take it from here.
Well, thank you very much. As everyone knows, working in surgery, it's your colleagues that make life good or bad for you in many ways. And fortunately, I'm blessed. And two of them here are coming up next. I'm going to first introduce Miss Aisling Kinsella, who is recently returned from Canada after a 4-year fellowship in Toronto, really in adult cardiac surgery and transplantation. Her main focus is, I suppose, adult cardiac surgery, but also extracorporeal perfusion models that she's going to explain to you here herself. So she's going to explain some scenarios regarding perfusing organs, heart and lung, outside the body, and how that may aid us in transplantation. And Aisling, if you want to share your screen there, you can go ahead.
Great. Thank you very much, David, for the introduction. I'm just going to wait for my screen. Okay, perfect. Can everybody see that okay?
Thank you. Yeah, you might go to slideshow, and that would be perfect.
Perfect. Okay, great. Thank you so much. So thank you very much for the invitation to speak this evening. Ever since transplantation became a global clinical activity, organ preservation has been one of the cornerstones that we've been developing. We've had significant increase in kind of research and developments over time in terms of how to protect and preserve these organs properly. And also we're looking at now how dynamic intervention by different perfusates can be used to kind of reduce any injury that the donor organs may have sustained, and also to try and improve the quality of the donated organs. So we've always been looking in terms of trying to safely transport the donor organs from the retrieval site to the implanting hospital.
I actually, sorry to interrupt you, but what we're seeing is we're not seeing the slideshow, if you don't mind. We're just play with it there 1 second. We're seeing the base PowerPoint. We're seeing the base PowerPoint presentation, but not the slideshow.
Okay.
It'll work through that. It'll look better for you if you.
Is it
Apologies. So if you click slideshow, just on the top ribbon, to the left, slideshow, and just from start from beginning.
From beginning.
And then we'll be able to see your slides.
Okay. Is that better?
It's not coming up.
Maybe I should put it in. I don't think I can go into.
I think if you go back into the sharing option, it'll be a different tray will pop up. And if you open share tray, I suspect there's more than one option there. And one of them is your slideshow and one of them is the base PowerPoint.
Here, I'll stop sharing. So open share tray. Oh, here, slideshow. Maybe that's better.
That's perfect. Thank you.
That's perfect. Okay. Okay, so as I said, we've been working to try to safely transport donor organs from the retrieval to the implanting site. The organs are usually cooled to 4 degrees, and that will help to reduce their metabolic demand. We want to avoid any potentially harmful consequences of hypoxia. And there's been significant research in ex vivo perfusion models and synthetic perfusate solutions. And this is to try and mitigate any injury to donor organs and also to improve the quality of any donor organs. And this is largely driven by several factors. One of them is the changing donor demographics. With increased road safety, we're probably getting older donors. And the other thing is that there's a rising clinical need for organs for transplantation across all specialties. So there's huge demand to increase the donor pool. So the model for ischemic reperfusion injury is common to, I think, all surgical specialties. And the severity of injury after reperfusion correlates directly with the interval of ischemia. And we want to aim to restore the blood supply to the organ in the shortest time possible. So our time limit for hearts is usually 4 hours and for lungs is 6. But that clock starts from the time you cross clamp the aorta to the organ being flushed and dissected and removed from the donor and then transported and then sewn into the recipient. So that actually ends up getting quite tight. So there's multiple factors obviously that feed into your ischemic reperfusion injury, between vascular leakage, inflammation, brainstem death and cell deaths. And obviously the most concerning factor is that this can all lead to primary graft dysfunction. So I'm going to talk a little bit about lungs first. So the ideal lung donor for us is somebody under 55. They've got a clear chest X-ray. They've got good gas exchange. We do an arterial blood gas on 100% oxygen with a PEEP of 5, and we're looking for a PaO2 of 30 millimeters of mercury, or that's a kPa of 40. We obviously try and avoid any chest trauma. We want somebody with no evidence of aspiration or sepsis, no purulent secretions, no organisms on their bronch, clear history in terms of any pulmonary disease. We prefer somebody without a significant smoking history, looking at their ABO blood group. Hopefully they've had no cardiopulmonary surgery, and then a size mismatch in terms of our recipients. The challenge for this is that the demand for donor lungs clearly exceeds the supply, and the donor lung can be injured by the mechanism of death within the donor, and this then includes things like fluid resuscitation, aspiration pneumonia, or if they developed a nosocomial pneumonia. So only about 20% of multi-organ donors ultimately have lungs that are suitable for lung transplantation, according to currently accepted criteria. I'd also say that the impact of COVID-19 has been very significant in terms of our lung transplant activity, both nationally and globally. So we now have to screen all of our donors for active disease. We have to screen all our recipients for any potential infection. We've had to develop protocols related to the vaccination and timing of vaccination, and also with regards to donors with a prior history of COVID-19. So at the donor site, the donor will have a blood gas done, as I mentioned earlier. You're looking at the airway pressures. They'll have a bronchoscopy done, looking for any secretions. The team will look at the donor's chest X-ray and the CVP. They do a deflation test. So when the chest is open, they'll deflate the donor from the ET tube will be disconnected to have a look and see if there's good compliance and if the lungs collapse. And they'll examine the lungs looking for any pulmonary masses. And then at the time of retrieval, then the lungs are flushed, with preservation while being ventilated, and they're usually explanted at kind of mid-ventilation. So for people who are lucky enough to be transplanted, like the outcomes are very good. So this is the ISHLT data. So the median survival post double lung transplant conditional on 1 year survival is 10.2 years, and for single lung is 6.5. So this is it's a very worthwhile endeavor, and these patients who are lucky to be transplanted do get pretty good outcomes from it. So, like I said, so driven by the increase in demand for organs and the change in donor demographics, a lot of groups have been looking at ex vivo lung perfusion. So with lungs, this has been developed greatly by the Toronto General Hospital, and this has been led by Prof. Kashaf Kashavji. Their lung transplant program do in excess of 200 lung transplants a year. So, and this is just some photos of so we have a very similar setup here in Ireland. So the general indications for ex vivo lung perfusion are, so you go out to a donor site and you do your gas and 100% oxygen, and your PO2 is less than 300. If there's any edema on the X-ray or on examination of the lungs at the site, if there's poor compliance, a risk factor for aspiration, which a lot of our donors will have, if there's maybe pneumonia on the contralateral lung, and also for DCD donors, that's also can be an indication for EVLP. So this is just essentially the setup. So you have the lungs here, they're connected to an ET tube and connected to a ventilator. The left atrium, it has a cannula inserted in it, and it's perfused essentially with a cellular solution, Steen solution, and that's perfused at 40% of cardiac output. You want your left atrial pressure 5 and PA pressure 10 to 12, and they're ventilated 7 cc's per kilo. They don't need to be hyperventilated. 7 breaths per minute, PEEPA 5, and 21% FiO2. So on the donor lungs, then obviously it's very easy. You can bring them back to your retrieval site. You can do a bronchoscopy. You can clear out secretions. You can have a look and see if those secretions are recurrent or not. And you can do a chest X-ray, and you can monitor the pulmonary edema on the X-ray. And if that improves over time, you do your gases and look at your trend from your PaO2 and make sure that that improves. And then I suppose the question is, if you're looking at all these marginal donors, like, are the outcomes going to be the same? So one of the main things we look at is primary graft dysfunction. So what's your PF ratio and what's your oxygenation of those lungs? So the Toronto group, this is one of the first papers they published. They were compared the EVLP lungs to a control group. So EVLP lungs came from DCD and NDD donors. So there was a total of 15, and these lungs went on EVLP versus control lungs. And essentially, they showed that the primary graft dysfunction, there was no significant difference between the two groups. And then they also looked at survival, and then survival between the controls and the EVLP groups again was very similar. So that's very promising. And then what is the conversion rate of EVLP for these donors? So on their initial experience, their utilization rates of EVLP lungs was 80%. So certainly very promising, because it is a time-consuming process. So EVLP, like I said, has great options in terms of improving pulmonary edema, the inflammation associated with brain death, treating pneumonia, aspiration, pulmonary emboli, and the ischemia reperfusion injury. One very good example of this is the opioid epidemic obviously has been huge in North America, and there's been a massive increase in young donors, and otherwise they would have very good organs but are Hep C positive, and these organs previously weren't used. So within Toronto, there was a prospective non-randomized trial. So they had donor lungs from HCV viremic donors who were transplanted into HCV negative recipients. And then before implantation, all of the HCV positive donor lungs were treated with EVLP with or without UVC perfusate irradiation. And that was to reduce the concentration of the HCV RNA and infectivity. And then all patients received antiviral treatment starting at least 2 weeks after transplantation. Their primary endpoint was composite of survival and HCV-free status at 6 months after transplant. So essentially there was 287 eligible patients, and they had 22 had HCV positive donor, 11 were put on straight EVLP, and 11 had EVLP plus UVC perfusate, and then they had 187 controls. So they looked at outcomes like the length of stay in the ICU, length of stay in the hospital, primary graft dysfunction. There was no difference, ECMO post-transplant. They looked at the survival and HCV status at 6 months after transplantation was achieved in 86% of the 22 patients within the HCV positive group. So 6 month survival was 95% in the HCV positive and 94% in the controls, which was very promising. And so then they looked at obviously the HCV status. So 91% of patients in the HCV positive group developed HCV viremia within the first week after transplantation, and then they had their antiviral treatment. And all 20 patients achieved negative PCR within 6 weeks of treatment initiation. I suppose I'm a little bit biased. I still have to mention something briefly about the heart. So, from a cardiac perspective, we're in this same position of looking at marginal donors. So marginal donors can be age, can be ischemic time, can be a donor with left ventricular hypertrophy. Maybe there's a history of drug abuse, some hemodynamic assessment, maybe some coronary evaluation that we need to do. The median survival post-primary heart transplantation by ISHLT is 10.9 years. Within Ireland, we're actually lucky enough to be 13.2 years. So these patients, if you can get them organs, will do very well. So the organ is retrieved from the donor. The aorta and the pulmonary artery are cannulated. They're connected up to a perfusate which within blood, and I have a video here of I'm not sure how well this is going to project. So essentially you have your heart within a box, and so you have defibrillation pads back here, and you can defibrillate the heart if there's any arrhythmias. You have pacing wires connected, so you can set the donor heart rate at 60 to 80 beats per minute. You can leave the heart on this for up to 3 to 4 hours. You trend the lactate within the donor, and you should see that start to clear. And you can have a functional look at the assessment of the donor heart, and you can time your theater to minimize your ischemic time, and so it has a lot of advantages. So the future for us for transplantation is to try and expand our donor pool to reduce our transplant waitlist mortality while still maintaining optimal outcomes. And the challenges of any program, I suppose, is always going to be staffing and training, but we're very fortunate to have a very motivated transplant group. So this is a very exciting area of development for us.
Thank you very much, Aisling. I think you have to unshare your screen there, and thank you. So I think we might do some questions at the end. I am looking at the chat function, but we might come back to any questions as a group at the end. I'll let our next speaker come in, and that's Professor Karen Redmond. Karen was a trainee in Ireland, obviously, and then worked in Brompton Harefield for a good while as a senior registrar before going to Toronto, and came back to London as a consultant in the Brompton Harefield, and long before Brexit decided that Dublin was a better place than London. So she came back to us from her consultant role there. She's part of our heart and lung transplant program, and here she's going to speak about some of her specialty interests, not the only specialty interest, but some of them, and it's on tracheomalacia and the airway. And if Karen, if you want to share your screen there, you go ahead.
That's great, David. Thank you for that. Just going to come up onto the video screen. Can you see that all right? Yes, fantastic.
Perfect, thank you.
Okay, so I'm going to talk a little bit about tracheobronchoplasty, which is the procedure that we offer to people with tracheobronchomalacia. And tracheobronchomalacia refers to weakening of the rings, the tracheal rings at the front. There's quite a number of rings at the front, depending on the size, maybe 12 to 18 or so. As opposed to dynamic airway obstruction, which often refers to the posterior muscle layer, or the trachealis, which can be very floppy and go forward. And what happens is it's a functional obstruction where between the cartilaginous rings at the front or the floppy muscle layer at the back, the airway will close, particularly in exhalation. And severe TBM, or dynamic airway obstruction, is defined as over 75% collapse of the airway during these dynamic moments. It's a very underdiagnosed condition, and I think it's one of the messages I want to say today for those people who are operating on people and struggle to get them extubated at the end of an operation. Up to 5% of patients undergoing bronchoscopy will have TBM, and 23% of patients with other comorbidities such as bronchitis. The Boston group have the highest series of TPM published, probably about 125 cases at this point. And the main symptoms that people will have will be cough and breathlessness. So of course they get treated for a whole range of conditions of which they may actually be present or may not, such as asthma. So for many, many years, people will have this diagnosis of asthma and will get repeat prescriptions of steroids. And with steroids, there's lots of side effects, including an increase in the BMI, including an element of gastroesophageal reflux, which in some ways may contribute to this very floppy airways disease, or TBM, that will happen. So if somebody comes to me and they have cough and they have breathlessness, and in fact they do have TBM, I can try to understand the extent of TBM with a dynamic CT and a functional bronchoscopy. And if they're over 90% airway collapse present, I'll do a trial of a Y stent, and if they get symptom relief, I offer a tracheobronchoplasty. If it's in the middle range, between 70 to 90%, then sometimes optimizing these people with, their medical comorbidities may help, dropping their BMI, pulmonary rehab, a cappella, expectorant, sometimes non-invasive ventilation will help, and less aggressive techniques such as laser therapy to the airway. If it's less than 70%, then again, we tend to reassure them and say that there are other reasons for their dyspnea. So the optimization process is important because if they close their airway completely, they struggle to expectorate. And quite often, with this element of secretions in the airway, or getting an element of gastroesophageal reflux and an element of inflammation of the airway, we often go down the route of using an a cappella or a flutter valve, Expedex and azithromycin. They may need non-invasive ventilation, and we work closely with the XWell group, who offer a remote pulmonary rehab program. So either virtually in your home, or hopefully attending classes with the drop-off of COVID numbers, people can get into an exercise program, which is important. So with the dynamic CT, we do an inspiration and expiration, and you can see here the difference between the two, clearly showing the extent of malacia that can be present. And in fact, we do reconstruction of the airway, so you can see this dynamic stenosis that's going on. So for example, here with this particular lady, she's quite obvious stenosis at the level of the left main, which is quite a common site for isolated tracheobronchomalacia. And you can see further down on the CT scan that there's an element of air trapping in the left lower lobe in particular, because I was to pick a very focus point of malacia, it's often affecting the left lower lobe, especially in people who are hyperinflated with background COPD. So when we're doing the bronchoscopy, we want to check above the focal cord, see what the aryepiglottic folds are like, see if there's any signs of reflux. If they've got obstruction above the focal cords, I like to work with an ENT surgeon. If they're below the focal cords, you'll see the extent of secretions, and we target lavage so that we can treat people if they're culturing anything. Often stenotrophomonas seems to be a big one for me. You can see the airway working at 3 different time points when you're under a general anaesthetic. Either they're fully muscle relaxed, in which case the malacia is at its worst. They're spontaneously breathing, and I try to get them to breathe at calculated tidal volumes that would be with normal breaths. And also I check them out when they're getting extubated at the end at coughing to see during the extubation process how bad the malacia might be. And a lot of it's down to judgment really at bronchoscopy to see what's happening. And sometimes, for example, this man was being checked for breathlessness, debilitating breathlessness. He was a solicitor and had stopped working for 3 years. And he said to me, I can't breathe when I lean over, which is quite common. I have a barking cough, which is quite common. And I feel like I'm breathing through salivating. And if you looked at his entire airway, you wouldn't really see very much. But if you get to the left lower lobe, you'll see as he tries to breathe in and out, the left lower lobe is completely gone further down at the 6 o'clock position, and the left upper lobe is also completely occluding away. So in fact, he was intermittently just losing his left side every time he tried to exercise and breathe more. And he intermittently was getting low PO2s. And so he was checked out for about 3 years for these intermittent low PO2s. He was looked for shunts, intracardiac shunts, extracardiac shunts, hemoglobinopathies. And in fact, it was at bronchoscopy that we came up with the diagnosis. So besides functional CT and bronchoscopy, you can look at PFTs, but just to say up to 20% of people with moderate to severe tracheobronchomalacia will in fact have a normal flow volume loop, so it's not absolute. And that would pan out as well with the PFTs linked to the demographics of the Boston group when they publish their data. There's quite a nice website. They do very good branding of their service in Boston if you want to go and have a check. We have to consider the operative risk with these people, especially when they're fully muscle relaxed, that in fact you might lose their airway altogether and they'll struggle to ventilate. And on one of my patients, we actually recognised this, and we had to do preemptive awake ECMO prior to putting a Y stent into him to give him the symptom relief that he needed. I suppose traditionally in the past, I quite often got calls from people because they failed to extubate people following an inguinal hernia repair or gallbladder repair or whatever. And it's, if you bronch them in the ICU and you see the tracheobronchomalacia, an undersized Y stent will do perfectly. And in my experience, they get extubated the following day. The type of stents you can use, the ones that we want to put in are the ones we want to be able to take out. And here's an example of a Y stent, which is a construct that is covered. And you can see it there in the airway on the left-hand side and with image intensifying. But stents can have problems. They can produce some secretions. In fairness, this stent is in a patient for over 3 years, and for other reasons, he's not suitable for tracheobronchoplasty. You can also get a fracture with stents put in. This chap was coughing a lot with the stent in, and you can see the posterior membrane in the midline as it goes forward with his effort to try and cough fractured. It took a bit of work to try and take it out. In fact, I lost the digital nerve supply to my left thumb for a couple of weeks, trying to pull this out of the airway and with a little hole at the carina. So I'm not particularly fond of stents. I think if I undersize more, I might have less issues with either fracture formation or mucus or granulation tissue. So with the surgery, I decided to go ahead because I had a number of patients that needed to be sorted, and medical management with stenting was just not enough. And so with that, what we do is we do a small, smaller than the picture, a posterior thoracotomy. We take the azygos vein, we mobilise the esophagus, and we fully mobilise the carina. And we go from above the vocal cords down to the right and the left-hand side with a mesh. The mesh is actually tailored to that particular individual. It's double layered. I size it during the operation, and I put the two meshes together with a stapling gun. I use an endo-GI stapler. And as the mesh goes on the back wall, as we work our way down the airway, I tend to put in 3 sutures, either corner, one in the middle, and the one in the middle is like a plication suture. So what it does, it helps to tighten the airway. And here's an example of a tracheobronchoplasty that I did recently, and you can see the mesh in place and it's working well. So I've done about 4 patients so far. I've started the program during COVID. I had a colleague who came from Leeds for the first one to go through it with me. I'd like to thank him for that. So the mean length of stay was only a day. I initially had planned for a week. The hospital length of stay was 11 days. There was no complications. And the follow-up, I'm really impressed with the outcome so far. People's dyspnea scale have gone from debilitating dyspnea down to an MRC scale of 1 to 2. And in fact, my last patient, who was the one who had the difficulties with the left distal, who was off work for 3 years, went from a 210 metre 6-minute walk test to 578. And he maintained his saturations. Initially, they were only at, he would get a level of about 34% expected. Now he's up at 96% in relation to his response rate. So he's done really well. So I'm just going to, this is one of the patients. I'm hoping.
My name is Patrick Lee. I'm a retired butcher. For a number of years, I've had a lot of trouble with my breathing. I was on antibiotics and steroids every couple of months, off and on. Didn't do any good. So eventually I went to see a Dr. Paul Blanchardstown, who I did a study with for 9 months. And he decided then to send me over to Dr. Karen Redmond, who proceeded to take me over, have a chat with me, and decided she would put in some kind of a little tube in my airways. After some time, I either coughed that out or it broke. I don't know which, but it came out anyway. So she decided she would opt for this new bronchoscopy. It was something new seemingly, and that she would do it. And I believed it was putting some kind of a mesh on the outside of my airway, which would strengthen my airways and make me breathe a lot better. I'm happy to say I am breathing 100% better. My quality of life is better. And I can walk, I can relatively do what I want. And I'd like to thank Dr. Redmond for looking after me so well. And it was a great idea and a very good success.
So just to move on, that was nice of Pat to say that. He was the chap who had the fractured stent in his airway. And so here's an example of another gentleman that I've done surgery on. You can see how I've placated the back wall. And over a couple of weeks, the mesh will actually stick to the back wall and stop the back wall from going forward. And you can see the plication all the way up. But at the very proximal end, just below the focal cords, I was running into some problems. Okay, so I couldn't access this particular point. He had severe TBM. He was the chap who'd been previously stented under a Waco ECMO, and you can see at the very proximal bit, he still had a little bit there that I couldn't get access to through a right thoracotomy, just right there. So the big decision I opted to
this bit here is so soft that it's flattening. The trach is actually flattening in my hand. See that? Yeah.
So we resected it, and we use a technique where we go tubeless for the tracheal resections, which has been published, and certainly surgical-wise it makes it a lot easier. So we resected just the posterior membranous back wall, we kept the front wall, and we resutured it back together, and he's done well from that. So they're a big investment, they take a lot of time. You have to make sure that you select the appropriate cases. Just to say that I've linked in with Sally Ann Crine and the College of Surgeons, who is looking at tissue engineering for trachea, and I will be looking for an MT student next year. If anybody's interested, if they could give me a ring. Thanks very much.
Well done, Karen. That was really impressive, and I love the plug for the cardiothoracic MD students. Fair play, and all letters too. So that's fantastic. There's a kind of, I suppose, a spectrum of. They're all thoracic topics, but I suppose there is a spectrum of them. If anyone wants to ask any questions, we have a few minutes to do that now. Really, the chat function is the best way to do that. So if anyone has anything they'd like to pop in, that would be great. One of the things that came up from people who registered in advance, Karen and Aisling, was the idea of simulation and how simulation can be used specifically in chest surgery, I suppose. I'm sure there's lots of general comments on that, but in terms of the kind of things that Aisling, that you were talking about there, and simulation for that, what kind of models can you use for those kind of ex vivo things? Are there porcine models, or what do people do?
Yeah, I think it's a good idea certainly to use porcine models, and it's certainly a very good place to start. And say particularly for the heart, it's very important in terms of how you cannulate and the length of aorta that you have and the positioning of the heart. I think that's certainly very important. And then the same for the EVLP circuit. It's very important that the left atrial cuff is a good size, and that's important at the time of retrieval. So there definitely is potential, to use kind of porcine models for that. Yeah, I think that's a great area.
And Karen, there is a comment or a question about the type of mesh and the biological or synthetic meshes. I'm sure you comment on. And is this the kind of work that you've done there? Is there any simulation model or practice model, or how do you start that stuff?
From a tracheobronchoplasty point of view, I suppose we could. I haven't thought to do that, but that certainly would be something we could do with the trainees, where you'd use a porcine model through the right chest. It's just about understanding the structures and mobilizing and working from there. But yeah, that would be very, very straightforward. It was a synthetic mesh that we used, but I have tried the biodegradable meshes. In fact, they were not HPRA approved, so I had to get special approval to have them over from the Czech Republic, and they were recommended to me by Martin Elliott out of Great Ormond Street at the time. And the deploying device is terrible, very difficult to put them in, and when they do absorb, they kind of go into like a little fishnet type of process, and you're pulling it out of the airway. And they didn't maintain the rigidity of the airway, because initially I thought, oh God, this is going to make my life so much easier. And I tried every other option, David, before I went down the route of tracheobronchoplasty. But in fact, traditionally I was told that it was an operation that was difficult and with little success in its outcome. But in fact, they're pretty straightforward cases, and the morbidity is minimum, and the outcome so far for me has been very rewarding.
Very good. Across the presentations today, I mean, a big thing is the technology, isn't it? And the new devices and developments in industry and all that kind of stuff. And you always have to be careful with that kind of stuff. But at the same time, starting with Karen, do you think, I mean, the kind of stuff you're doing requires some sort of sharing of insight? Is that the right word, or direction? I mean, you have to, the companies need to know what's important to be told, you know, where we need developments. Do you think that's your collaboration there with
Sally Ann?
Regeneration? Yeah. So that kind of stuff is important, I guess, is it? Do you think, for a surgeon to be involved in?
I think so. I think it's key, and it's only when we started chatting did she recognise, I suppose, from a clinical perspective, what kind of problems needed to be resolved and how we could complement each other. So there's a little bit about the biggest morbidity about putting a stent in, despite the fact that it can help, is granulation tissue, migration, mucus plugging. So you need to have these kind of anti-proliferative properties coating the stent. And then the other thing I would say is cough. It causes a lot of cough in the airway, and cough can be quite, like, it's a foreign body in the airway, it can be quite debilitating. So how can we limit the cough issue? And there's, you know, I've been looking to maybe towards cryotherapy for that, to try and denervate the airway prior to stenting in a certain cohort of people. But quite often we've been stenting people, David, who've had radiation for cancer, and so they don't struggle as much, and unfortunately their survival is not as long, so they don't tend to run into the problems with stents like people with benign disease will.
And Aisling, Karen, you might unshare your tray there as well. Aisling, I mean, the kind of stuff that you're commenting on there is heavy technology items, and you've come back from Toronto, where I think Shaf Khashoggi runs it nearly like a business. I mean, is that the kind of model that we should all go in, or how does he run his model there?
Well, I think just I think what you said to Karen is also very relevant. There's also always huge concerns about being an early adapter kind of new technology, but I think if you've got good international data, which we do have on ex vivo, I think it's a great option to explore. With any new technology, I suppose there's always the question about funding and how do you staff these things, which is a problem. And I think, you know, for a smaller transplant program in Toronto, it's important to start conservative and kind of work your way up. In Toronto, they have like a whole model of kind of research fellows that run the ex vivo. So that's going to run is independent essentially of the consultants. So they come in and they run the EVLP, and then they just ring with their 3-hour report. So I don't think and a lot of them are kind of unpaid. So we're not going to get to that model. But there is a potential, you know, as we expand our retrieval team, there's, you know, there'll be a consultant buy-in certainly at the start, and heavy involvement at the start in terms of getting the retrieval team up and trained. But I think once you get to that point, and if you're using it frequently enough, I think people will have enough experience, and that it'll become something relatively routine that we will be able to do.
And do you think it'll be, how are you going to assess a trainee's competence to do what you've described there, Aisling? Is that straightforward to do or complex?
Well, no, I think it'll be very similar in terms of how we assess the trainees or assess people for to sign them off that they are allowed to retrieve organs for transplant. So I think it'll be very similar. So they'll have to do a certain number of cases supervised, and then they'll do some independently, and it'll be assessed. Their process, the whole thing has to be assessed, I suppose. That's their competence with the procedure, and that they've clear guidelines, and that the implanting surgeon is happy with how the process has been carried out.
Okay, and last comment to you, Karen, the same question. Training, tracheomalacia surgery, how are you going to sign off, or how do you think you're going to measure a competent trainee for this?
Difficult, isn't it? Because in thoracics, it's just, you can't keep up with medical technology. Like your talk today was excellent, David. There's so much going through between airway, robotics, pectus, ablation, cancer work, chest wall work. So there's a lot for one trainee to get through to become a specialist thoracic surgeon, especially if they have a particular interest in something like lung transplantation. And so they're going to need the dedicated time in theatre and one-to-one. And you all kind of train in theatre. I think that's going to be important. But to get the caseload through, probably the animal lab facility, as you mentioned, would be the way forward to put people into a comfort zone, especially when these cases can be a little touchy at the table. So, you know, in the animal lab facility, you can ask all the questions that they need to ask, and you can slow down and take your time with them.
Okay. Well, it's 7 o'clock. If the president wants to comment, that's more than welcome. I don't think there's any other questions on the chat box. If people are happy, we would be delighted to discuss this further offline or in any manner people wishes in due course.
Sorry, President, you are on mute.
No, I'm having gremlins in my works as well. Can you hear me now?
Yes.
Yeah. Thank you to all three presenters. I really think we've heard the cutting edge of transplantation, of robotics, and of tracheal surgery. And it's wonderful to see young surgeons pushing the boundaries and keeping us up to date in Ireland. So well done to all three. And no doubt you will be brought back maybe in the next semester to update us on other things, but it's wonderful. Next week, we hope to have a very interesting presentation from Pakistan, as well as from some of our Pakistani colleagues here in Ireland, to update us on the situation in Pakistan. Fortunately, it seems not to be as desperate as it is in India at present, but they are experiencing another surge in COVID cases, and to see how they're coping with the effects on training and service delivery, but also to reflect on how many Pakistani surgeons are working in Ireland, and equally quite a number have gone back to Pakistan and may reflect on their experience in Ireland. So I hope that will be of interest to many of our fellows and members, and we look forward to that. As always, I thank the Vice President, Laura Vianney, who's instrumental in putting all of this together, and the backroom team who keep us on the straight and narrow. And I wish you all good evening.
Thank you.
Thank you.
Good night.